Welcome to Mastering Mastocytosis, the first webinar of a series of the Mastocytosis Centers of Excellence and Reference, MAST²CARE, an initiative of the Galen Asthma and Allergy Excellence Networks, aiming for fostering awareness, education, and harmonization of care for patients with mastocytosis. My name is Frank Siebenhaar, and I'm very happy that we have a very gifted expert faculty for you today. With me is Polina Pyatilova, also from Berlin, Sigurd Broesby-Olsen from Odense, Denmark, and Vito Sabato from Antwerp, Belgium, all very nice and friendly colleagues and friend of mine. Before we start what we want to achieve today, by the end of this webinar, you should be able to better recognize the signs and symptoms of mastocytosis and also understand the underlying mechanisms of the disease pathology and to also better navigate through common diagnostic hurdles. So to achieve that, we have assigned a program. Polina will start with giving us an overview of the definitions, types, and disease spectrum. Sigurd then will take over to talk about our most important, let me say, instrument in the diagnosis of systemic mastocytosis, the KIT D816V mutation, and why it matters. And then Vito will discuss with us the challenges in real-world settings in the diagnosis and also the management of patients with mastocytosis. In the end, if we have time, we will also have a Q&A, and I explain you in a minute how you can share your questions with us. If you want to stay tuned with MAST²CARE and Galen initiatives, please join our website. If you even want to become a MAST²CARE, also find information on the website. We're very happy to help you. There's a bit of a formal process to walk through, but let us know your interest and we're very happy to accompany in this process. Also, and Polina will probably touch upon this, the flagship project in MAST²CARE right now is the MAST-Have app, an app that enables better interaction between you as a physician and your patients with mastocytosis. Also a research tool we are being used in the MAST²CARE community. If this app is not yet available in your country or you don't know, also pass out a question. We are very happy to work together with you and bringing the app also or making it available for your patients in your country. So here there's the two options how to share your questions. There is the Q box in which you can type in your questions without your name anonymously or just easily use the Zoom chat function. And there's only the name you gave yourself in Zoom. So both options are available for you to type in your questions. Whenever possible, we will touch upon your questions and have them answered by our experts. So not losing any more time with this, Polina, I will give the first presentation and the stage to you.
Thank you. Thank you, Frank, and also welcome from my side. I'm very happy to start the first MAST²CARE webinar with this big topic where I will try to touch, I think, about a little bit about everything. So to get you and dive into mastocytosis. So what we know that mastocytosis, it is a rare disorder by definition, what we know by now. And what means mastocytosis? It means that there are too many mast cells and they are atypical. So they're neoplastic mast cells and they can sit in different organs, in bone marrow and skin, in spleen, lymph nodes, or other organs like GA tract, for example. So we know that it's 1 per 100,000 can have mastocytosis and the prevalence is 10 per 100,000. But also, I asked the question, is it really a rare disorder or is it an underdiagnosed disorder? And here you see that the incidence, this is the data of their the Danish registry, which show that there is in 2018 already, the incident is tremendously increasing. So it's 3 times increased. And I think it's also gives us a good feeling that maybe it's a very underdiagnosed disorder, and with good tools, especially in Denmark, where Sigurd will tell us about KIT mutation. The tool which helps us to diagnose mastocytosis is also frequently used. So a little bit about their definitions. We know that there is cutaneous mastocytosis, and it means mostly it's in children. So it's only these mast cells are sitting in the skin. And we also have systemic mastocytosis, and this means that also not only skin, but other organs or bone marrow, what I also mentioned before, are being involved. And this is our main topic today because it's a big challenge. But what we have to know that there is different forms of mastocytosis, but indolent systemic mastocytosis is the most prevalent one. So it means that the patients are not in danger. So usually they have a normal life expectancy, and they don't have this advanced form. So this is from the beginning more likely that your patients will not have aggressive mastocytosis, and that's why we will not focus on this today. But what these patients have, they have this mutation, and what it means that usually mast cells, they need the stem cell factor to grow up. But when this mutation, which is mostly seen in almost all of the patients, is there, then they don't need any other factors to grow. So then they grow and they can also form groups in these organs, what result into the symptoms. And here comes the challenging part, because this is a very heterogeneous disorder. And we know that there are many symptoms which the patient can experience. So every second patient could experience anaphylaxis. Most of the patients, because we also can easily see this, they have skin involvement. So typical mastocytosis lesions. Every third patient could have osteoporosis. And there are also GI symptoms like diarrhea or nausea, and also unspecific symptoms, which is a big challenge for us to think if could be mastocytosis. But what they also all have in common, that we already talking about systemic mastocytosis. So again, it's mostly indolent systemic mastocytosis. And here's a bit, here I will want to show you 3 examples. So what first comes also into your mind, could it be all mastocytosis? And yes, it can. So the first you see a young a man with bone pain. So he was then diagnosed with osteoporosis. So this could be a classical sign of mastocytosis with bone involvement. In the middle, we see a lady with flushing, with also gastrointestinal symptoms. So she doesn't have skin lesions, but in the end, she was also diagnosed with mastocytosis. And then the young lady with typical skin rash, which in this case, we also see that this is mastocytosis in the skin, but highly likely she, of course, will have indolent systemic mastocytosis. So 3 absolutely different stories, and this is all mastocytosis. And what helps us to better define the patient. So this is again, we will, I think, go through this KIT mutation all through the and remind ourselves to test for this all through all of the symptoms, because this is the test which will help to define the patients. So let's start with the skin involvement. It's more than 90%, because it was also one of the first symptoms which was known as mastocytosis specific symptom. You see the typical lesions. There are small red-brown lesions. Usually they are also symmetrical all around the skin, and they also start usually at the legs. This is, I think, also important to maybe wants to see it in live, because if you're a dermatologist, it could be also not sometimes easy to say it's mastocytosis specific lesions. What also is typical that the skin of the face and neck is usually actually not being affected. So that's why we all already can differentiate with other diseases. And we also see absolutely different intensity of the involvement. You see from A till F. So this is from limited macules, papules, what is really difficult to diagnose, to really very extended skin lesions. And what they do, um, if we touch this lesions, so after rubbing this lesions, and you also need to do it really intensively, these mast cells which are sitting in these lesions, they're being activated, irritated, and then we see a swelling, and this is very typical for mastocytosis patients. The second feature I would love to focus, it's anaphylaxis. So in different studies, up to every second mastocytosis patient was having anaphylaxis. And just to focus, who are these? Not every anaphylaxis patient is mastocytosis patient. And we have the score, which was developed by a Spanish group, which helps us to identify who are these patients who need further investigation. So you see this is male patients without urticaria, what is also important. So they don't have in this episode of anaphylaxis any skin involvement. So they experience this really differently. And of course, tryptase level, and tryptase is being produced in mast cells and being extracted from the mast cells. So it also helps us to define how many mast cells sit in the body. What we also need to know about anaphylaxis, we know that Hymenoptera venom allergy is the main trigger of anaphylaxis, and you see different studies. There are many, many studies of them, Italian group, also Spanish group, also from Belgium. Many studies show that, like here, so patients without skin involvement usually are being diagnosed because they experience venom allergy and have induced severe anaphylaxis. And the other study says also the same, that without skin lesions or with mutation, the patient mostly would have insect venom anaphylaxis. When the skin are present, we see that also very often we cannot identify the trigger. So it's not that we are not testing for this, but it's after all this testing, unfortunately, the trigger is not, it cannot be defined. So we say be aware to our patients, and also think about mastocytosis when there is a severe insect-induced anaphylaxis. Another German study showing that also same message, that the patients with mastocytosis with insects, also males and elder patients, are more likely to have mastocytosis and severe anaphylaxis. I want to touch a little bit about other triggers like drugs and food symptoms. And this study also showed that after provocation tests, the patients, the allergic reactions were the level was the same as in the placebo group. So we know that there is no evidence for now which could support that the patients need to undergo specific diets or avoid drugs. And this we need a lot of work to also, I think, to talk more about this. This is again also from Vito. The studies being shown also in Sweden, in Belgium, which also say the same about the drug-induced anaphylaxis. It is uncommon in patients with mastocytosis. Next, osteoporosis, the feature number 3. So every third patients have osteoporosis, and we don't know yet why it's exactly and who are these patients with osteoporosis. But as I mentioned at the very beginning, young men with osteoporosis, which is unusual. So think about mastocytosis. We know that there is in the literature this balance between osteoblasts, who helps us to build bones, and osteoclasts, who are more actively resorb their bone tissue. So they are so this balance, they are disbalanced, and also inflammatory cytokines were mentioned to also affect this, to increase this effect between osteoblasts and osteoclasts. And there are some patients who doesn't have who doesn't have just reduced bone tissue, but other way around. So they have too much bone tissue, which is called osteosclerosis. So it's as a glass, it's also dangerous. And sometimes it is also underestimated, but we know that up to 10 patients could, 10% of mastocytosis patients could have this osteosclerosis. And it's what is also shown, it's actually an unfavorable prognostic factor. So these patients with indolent systemic mastocytosis should be controlled more precisely to avoid progression. Again, we love scores. We have another score which helps us again to think which osteoporosis, a common disorder, which patients could have maybe mastocytosis. So this is again young patients, younger than 55 years old, with vertebral fractures specifically, and also tryptase level will help us in this case. And finally, gastrointestinal symptoms. In different studies, different frequency was mentioned. The patient could have diarrhea, abdominal pain, nausea, vomiting. And this study was showing also that in ileum, there were the most amount of these neoplastic mast cells. But what is interesting, that also in many cases, there nothing is being seen endoscopically. So their mucosa looks absolutely normal. So this is not their obligation to diagnose this patient. So the symptoms is enough to undergo the further procedures. And there are specific diagnostic criteria for systemic mastocytosis. There are Mayo criteria in the bone marrow, and this minor criteria also in bone marrow, not always easy to perform. So we need to confirm that there are more mast cells than should be, and they are not looking as normal mast cells. But there are two things which we easily can do: tryptase level, numerously mentioned, KIT mutation. Sure, Sigurd will tell you more about this. And there are B findings, C findings, which show us how high is B finding, how high the burden is. There are specific also amount of mast cells. I will not go into detail of this. Yeah, but this is the diagnostic procedures which should be done in patients with mastocytosis. And C findings, cytoreduction, which just help us to exclude aggressive forms. And this is again why it should be done, because then you can easily say we exclude aggressive forms, and we focus on the burden of the disease. And what it is, it's symptoms, what I already mentioned, the quality of life. We know that patients have a tremendous impact on the quality of life, exactly which symptoms they have, and finally the mast cell burden. And we also need to know that about every second patient does have severe disorder, and that's why it's precisely every symptom need to be checked and discussed with the patient. So I'm at the end of my presentation, and there are take-home messages which I for you. So if it's not rare, it's just unrecognized. The KIT mutation is central for the disorder. Anaphylaxis without rush could be mastocytosis. BUS also could be mastocytosis. Think about combinations and patterns, not a single symptoms. Osteoporosis, test early, not wait for the fractures, and also focus on the burden, not on the tryptase or tryptase levels. And finally, don't over-restrict what is not proven. So not every mastocytosis patient needs to avoid everything. with this, thank you for your attention, and I'm happy to answer the questions.
Polina, thank you so much for this, very concise and very clear overview on the subtypes, and also the diagnostic maybe pitfalls. I must tell you, you gained most attention by saying in the beginning, mastocytosis is not a rare disease. It might be just rarely recognized. So there's a couple of questions that actually ask towards what are your tips for every clinician to not miss mastocytosis? So where are the hidden cases in your opinion?
As mentioned, try to structure yourself. So to look at the main symptoms and also guide the patient when you talk to the patient, because there would be a lot the patient can tell you. So first, look at the skin. Is it there or not? If it's there, it's already indolent systemic mastocytosis, more likely. Is it something with the bones? Check this. Anaphylaxis, and especially if it's insect-driven anaphylaxis, if it's grade 3, 4, so it's severe anaphylaxis, always mastocytosis should be checked. And how to check this, Sigurd will tell us with the
Super.
kit.
That's the
Yes.
perfect transition to Sigurd's presentation. Thank you so much, Polina, for your very nice presentation. And Sigurd, I will hand over to you for the KIT D816V mutation and why it matters. Sigurd.
Thank you very much, Frank. I'm hoping you can see my screen in a minute. Does it work?
We see your screen, but not in the presentation mode.
Okay, I'll try
it.
it.
Working mode.
Let's see if it works now.
That's perfect.
Thanks. So first of all, I mean, Polina really nicely outlined this. First of all, a great thanks to you and Polina for the MAST²CARE initiative. I think it's really exciting times to be working with mastocytosis. It has been under-recognized, it has been under-treated, it has been underdiagnosed, and I think there is an increasing focus on this disease. It's really in the gain of our patients and also new treatment options coming. So I think it's really a good initiative to have this and also to have this webinar. These are my disclosures. So I think I had 3 main points I wanted to include in my presentation. The pathogenesis of mastocytosis is really dependent on KIT mutation, and nicely shown by Polina. KIT D816V is the mutation that we mostly talk about when we see adult patients. Secondly, really interestingly, we can detect this mutation in peripheral blood, which means that we have really a strong and specific diagnostic tool and also a prognostic tool. I'll come back to that. And then finally, of course, given the fact that this is the driver mutation, tyrosine kinase inhibitors that target this mutation is, of course, a really intriguing new treatment option way, because so far we've been really left with symptomatic therapy in indolent disease. So, but I'll just touch briefly on that. So this is a slide or a cartoon that I borrowed from Frank, actually. So it does show some of the same things that Polina touched on. So in all of us in health, the KIT and the SCF interacts in the way that the mast cell numbers are well regulated, and the proliferation, differentiation, and survival is nicely controlled. But then if we turn into the situation of mastocytosis, the KIT mutation is, or the KIT receptor is no longer really dependent on SCF. It does have the speeder more or less pushed down. And so in that way, we have a prolonged survival and then a clonal accumulation of mast cells that are not normal. And this is the situation in almost all adults with systemic mastocytosis. So if we then, and when we could discuss whether these mast cells are actually then functionally normal. But anyway, when we then do a bone marrow exam, and maybe, I don't know if you can see my arrow, but anyway, at least you can see these elongated, spindle-shaped brown mast cells that are, so they're not easily recognized, but but so you need experience from a pathologist, but they are not normal mast cells. They are increased and they are altered. And also you can see the markers here on the flow cytometry. So just saying that the bone marrow exam is not trivial. You need really expertise and you really need good methods to also really investigate whether this patient has systemic mastocytosis. This is a little bit too complicated for the webinar time limit, but just saying that there is beyond or downstream of the KIT mutation, a lot of changes in the regulatory proteins, transcription factors, and other things that actually might also be targets for therapy. But so there are things there yet to be investigated. But then moving on to the diagnostic situation, we had in our center in Odense a situation where we did not find enough KIT D816V when we did the bone marrow exams. And my colleague Thomas Christensen looked into this, and he actually invented a new method that actually showed up to that we are able to detect the KIT mutation in peripheral blood, though we know that they are not circulating mast cells. They are not. It is not a leukemia. And this is really interesting because that gave us the opportunity actually to more specifically detect the disease in a non-invasive way. Since then, there have been a lot of publications out there using this method, and it has been also incorporated in diagnostic algorithm. There are now commercially available tools, Pentabase, other companies working with this. So I really emphasize this as an important tool that you need as a allergologist, as a dermatologist, as a hematologist looking for these patients, and even beyond, as shown by Polina, also in other specialties, for example, in osteoporosis clinics or clinics working with GI disease, for example. You really need to apply this tool more often to not overlook mastocytosis. Just a little bit technically, and also beware that you use the right technique. You really need a highly sensitive method. I will not go into the detail, just saying that a normal blood sample from a normal indolent systemic mastocytosis patient, you really need to go below 0.1 or 0. Even lower percent mutations, which is what is achieved by the techniques down here. While for example, the older techniques or the PCR technique that we used before, or even next generation sequencing, will most often give false negative results when you use it on the peripheral blood. So please use the right methods when you do this. But this leaves us also with another tool that supplements nicely the other tools that we have in the clinic when we look for mastocytosis. Shown by Polina, skin lesions are there in many patients, but it does not need to be there. You can have mastocytosis without skin lesions. Tryptase is often elevated, but it may be completely normal in patients with systemic mastocytosis. And by normal, I mean even levels below 8 or 7. And it can easily be systemic disease also below 20. And on the other hand, as you all know, we have a new player in town, hereditary alpha tryptasemia, that is not equal to mastocytosis. And you can have elevated tryptase not having mastocytosis. So basically, tryptase is not the specific tool. Polina already mentioned REMA score. That is a nice tool, but it's, again, maybe not the perfect tool. And now we have KIT mutation in peripheral blood that does have limitation, but it's a nice supplement to the others. And this is what we do in the clinic. If we, for example, have a patient with anaphylaxis or a patient with elevated tryptase with maybe unspecific symptoms, then we look for the skin lesions. If they are there, this will probably show indolent systemic mastocytosis. The next and limiting step will be to look for the KIT mutation in peripheral blood. If it's there, we will file systemic mastocytosis in that patient. On the other hand, this also means that we really need convincing symptoms to pursue the journey for mastocytosis, because in that way we also have an non-invasive technique to exclude mastocytosis. We cannot do bone marrow exams in all patients that we see. So these are some of the doors to proceed with the workup for mastocytosis, even though the KIT mutation may be negative. Maybe Vito is going to touch on that, because of course, sometimes we have a negative results, but still have systemic mastocytosis. But most patients are really positive, and then you can rely on a negative result as well if these symptoms are not there. Let me have an example nicely fitting with the first presentation. So this is a female with a severe anaphylaxis, otherwise completely healthy. She does have elevated IgE, but please be aware it's below 0.35. This is important in mastocytosis, that patients can have significant elevated IgE even below 0.35. But basically, the tryptase is normal. She does not have skin lesions. And when we add up the different elements of the REMA score, as you can see, this was not a patient that you normally would expect to have mastocytosis. But then if we have the KIT mutation, you can see that it's positive. The workup shows systemic mastocytosis. And for practical and also really importantly prognostic reasons, this is a patient that should have lifelong immunotherapy. If we stop immunotherapy in a patient with systemic mastocytosis, they will have a new anaphylactic episode that can be life-threatening. So this is, I think, really an important point for me. You really need to look at the whole patient and also use the different tools complementary. On the other hand, I think we all see these patients with unspecific symptoms. Maybe they are self-referred or expecting themselves to have either mastocytosis or maybe MCAS with a lot of diffuse symptoms, and also really worried patients. And you can not really find a pattern in all the symptoms. Every time you ask the patient about symptoms, they say, yes, I also have that. If you then apply some, and this was an example from our clinic, we don't see any skin lesions, we cannot see any tryptase elevation, it's not really episodic, and then the KIT mutation is negative. So in that situation, I think we can nicely rely on the negative test also to reassure the patient that you do not have mastocytosis. So I think in that way, the tool is nicely fitting with a clinical need. You cannot blame the patients, because really, when you look into the internet and see what is published out there of symptoms claimed to be related to mast cells, where to start, right? I mean, you can have publications showing all these stuff with all the different really pointing to anywhere where you want. And this is just page 1. Now we have page 2. So of course, patients are really concerned and over anxious on this topic. So I think we need to help ourselves also be a little bit more specific on what symptoms we actually can attribute to mast cells and mastocytosis. I've put up my, let's say, suggestion for this. Of course, you have patients with severe anaphylaxis, with hymenoptera anaphylaxis, with immunotherapy failure, with recurrent idiopathic anaphylaxis, with osteoporosis early onset, especially on males. You really need to look for mastocytosis. You will most often find it. We have, of course, unspecific symptoms that many of our patients already diagnosed with suffer with. And here, of course, you need to look for mastocytosis, but it may be also other diseases, of course. On the other hand, I think we also need really to be a little bit more strict on what we do not see in mastocytosis. And I don't see, for example, angioedema in my patients. I don't see urinary symptoms. I don't see eye symptoms or distal joint pains, neuropathies. I think we have to be a little bit more critical on what we put in our diagnostic pathway. So just ending my talk on the third topic, that is prognostics. And I will not touch much on allele burden, but just briefly touch on pediatric mastocytosis, because mastocytosis is not only D816V, it's also other KIT mutations. And I think Polina mentioned this. So if we have pediatric mastocytosis, I think most of us is aware that when we, first of all, have adult mastocytosis, you can see almost all of them have KIT D816V. While we turn our heads into pediatric mastocytosis, only a minor part of it, maybe 1/3, does have this, and other KIT mutations are prevalent. And could this also be some kind of prognostic feature? I think yes. I think there is an increasing awareness that if we do not have KIT D816V, there is a bigger chance of outgrowing the disease. As you can see in this child growing up and nicely getting rid of her skin lesions. This is actually not is a cafe au lait spot, but so, and this patient did not have KIT D816V. It was wild type, even in skin and blood. And then this child with the monomorphic skin lesions, actually, it does seem to improve, but here we could actually detect the KIT mutation in peripheral blood. In spite of that, it still seems to regress, but this is a patient that I will follow up even beyond the age of 18 and probably also look into the bone marrow to see if there is systemic disease. So in that way, it might be also a prognostic tool. And then finally, this is the KIT mutation is also the pave or the way to a better understanding on how to treat mastocytosis. And we are far beyond imatinib, that was the old tyrosine kinase inhibitor without any effect on D816V. We have new KIT mutations, KIT or tyrosine kinase inhibitors coming up with these exciting times to be a doctor for these patients. So I'll sum up now, thanking my team and also again thanking Frank and Polina. Thank you.
Sigurd, thank you. Thank you so much. I think you explicitly pointed out the importance of the KIT D816V mutation analysis in the diagnosis of mastocytosis. And I have a couple of questions for you. I will cut it down to 2.5. So one is, for all of our participants, they now, think about it. Okay, I should start implementing this method, and the right method, because a sensitive method in my hospital, in my clinic. What is your tip? How to start, how to achieve, how to come to the right assay, and how to get access to it?
Yeah, I mean, basically you need, like, if you're not a lab doctor, I think you need really to ally yourself with either the immunologist or pathologist that works with molecular diagnostics. And then just knowing that there are commercial assays out there. I do not have any, let's say, conflicts of interest there, but I know that our company is offering this, the nicely sensitive techniques that you can apply in your clinic. And it's not really that costly. So I think that would be the way. Talk to your lab and then find the right companies offering these tools, and then you can start doing it. And we are always ready to help if you need some reference or some guidance in that sense. Thank you.
Super. Yeah, super. Now comes a difficult one, Sigurd, and I think this is a question you asked yourself also many, many times before. So, dear doctor, thank you for the excellent talk. Given that the KIT D816V mutation is present in the majority of adult patients, or also in some of the children, as you pointed out, why does mastocytosis typically present as a benign self-limiting cutaneous disease in children? And why it's either chronic stable or even progressing, sometimes even to really aggressive systemic mastocytosis in adults?
Yeah.
And is there epigenetic or any other genetic drivers that explain these different phenotypes?
I mean, this is really an excellent question, probably posed by somebody either knowing about the disease or really curious. I think that I really appreciate that question. I don't have the answer. I don't have really the good tool of how the trajectory of each patient is, because it's completely true. We do not understand why the skin lesion seems to disappear, for example, in children, and also in the elderly sometimes. We do see patients that progress, even though that's not the typical sign, and most patients are stable. So it seems like a new steady state comes to these patients, even though it's a clonal disease. And I do not know the molecular basis on this. It's just like the reality that we have. So it's something that we need to elucidate. But thanks for the question.
Super. Thank you for the answer, Sigurd. In the more advanced forms of mastocytosis, and especially in those who also suffer from an associated hematologic neoplasm, we do know that additional mutations may also, may be the driver of making the disease aggressive. Here's a specific question of, you are aware whether this could be also of potential need in children to look for additional mutations in the peripheral blood?
So I would first of all, I would emphasize that aggressive disease and even associated hematological diseases does not really only rarely present in the pediatric population. They will probably also have other signs of hematologic disease, which then would lead to you looking for other mutations. But it is true that, I mean, some of the mutations that drives the mastocytosis are not D816V. And for example, we do skin biopsies, we find other than D816V as a KIT mutation, so to speak. But we do not at this point routinely look for, let's say, non-KIT mutations or something completely different. My guess is that most children does not have this from a clinical perspective. They have mostly only mastocytosis. So I don't think we will find much, but it's an interesting question, and I don't think I really know whether the other mutations are there.
Super. Is there actually KIT mutations, Sigurd, known in people without mastocytosis?
There are some hematological disease, myeloid malignancies, but sometimes we find it. I think there are indications that other cells also may be affected by this, but in the sense of a diagnostic tool, I think you can be quite specific. If the D816V is positive in peripheral blood in a setting of indolent disease or a non-malignant clinic, I think you can rest reassured that this will be mastocytosis.
Super. And you also pointed upon, the value of the KIT D816V mutation as a prognostic marker. Maybe, Sigurd, if you're going to elaborate a little bit more on this, because here's a specific question saying, how can the evolution of indolent mastocytosis towards more aggressive forms or a progression, how should it be monitored?
Yeah, this is not a black and white question, because it would be intriguing to say that if you, for example, I mean, what we're talking about is that the KIT mutation is not yes or no if we measure it in blood. We actually have a percentage on that. And as I mentioned, most of the patients will have really, really, really low amounts of DNA or allele burden. But we do have patients with higher levels. And if you, for example, have 10% of cells circulating with the KIT mutation in peripheral blood, that could indicate that this could be a patient with more cell lines involved and then also progressing. But it's not a black and white matter. And I think we do have patients in our clinic with a mutation level of 10 or 20 for 25 years, 30 years that did not progress. On the other hand, we do see sometimes, rarely, that they are progressing from lower levels. But it has been postulated that around 6% would be a division of whether this is truly indolent disease or this could actually progress into smoldering disease or maybe even other forms. But these are good questions and really also advanced questions. So I'm really happy about that. Thanks, Frank.
Yeah, and it seems like we have a couple of pediatricians in the audience. So my last one, Sigurd, because or the last one I can pass to you. There's a couple more questions now, but because you showed also the childhood cases, maybe if you can point towards again, because the question is CD117, so KIT staining in a skin biopsy, enough to diagnose cutaneous mastocytosis in a child?
So first of all, you need the clinical situation. So you need the urticaria pigmentosa or macular-papular cutaneous lesions that was shown in the picture. So we have so far not seen a single child without these skin lesions. So first of all, have a look into the skin, do the Darrier sign, make sure you are there. And then if you start then looking, of course, you need to apply the right markers, tryptase staining, CD117. You could also apply others, but I think basically the normal diagnostic situation in a child with typical skin lesions, I don't think you actually need the skin biopsy in that sense. On the other hand, you should be really careful on doing biopsies and then counting mast cells, because this is not the way of diagnosing mastocytosis. The number or density of mast cells does differ in different areas of the body. So just starting to count mast cells, saying they're increased, and then saying the child has mastocytosis, for example, also on gut biopsies, I think that's not the right path. Here you need to be more specific on your clinical and also the questions that you ask for the pathologist. But again, a good question.
Super. And then really the last one, because it's a burning one. What's the value of tryptase, both in adults and more specifically in children? Is there cutoff values? Is there correlation with any other? I know you answer, but the question is specifically inflammation markers like CRP.
No, I don't think we have the good, as I mentioned, you can have really severe typical indolent systemic mastocytosis and then a tryptase of 10, for example. And you can have a situation where your only symptom is maybe skin lesions, but nothing else, and a tryptase of 100. So these things are not equal to symptomatic burden. And neither I have any indications that this could be inflammatory, let's say, parallels or equivalents. So I don't have an answer to the last one in specific, but I just think that you should use tryptase cautiously, both in diagnostic and also for the monitoring. I think it's good to monitor tryptase, but as Polina mentioned, the important thing is the symptomatic picture for the patient, and try to tailor your therapy and workup and counseling onto that patient.
Super.
Yeah.
Sigurd, thank you very much for all the answers you gave, and thank you to the audience once more to this very good and well taken questions. So with this, we come to already the last talk of this webinar. Vito, it's your turn on the diagnostic challenges in real-world settings.
Well, thank you very much again, and thank you very much for this webinar. I'm really enjoying it. And let me say that actually we can save some time because some of the challenges have been already solved or have been already discussed during the Q&A. Well, those are my disclosures, and I will start with these. I mean, we know that actually it's probably an underdiagnosed condition, so we need an high index of suspicion, also because we have a low prevalence, but also non-specific symptoms. And those are the conditions that have been described as conditions that should raise the suspicion of mastocytosis. First of all, having cutaneous lesions, and specific cutaneous lesion might be indicative of eventually a systemic disease, such as, for example, adult onset, a monomorphic variant, anaphylaxis has specific features of anaphylaxis, and osteoporosis has specific features of osteoporosis. Let's start with the skin. You have already heard that actually the first challenge is recognizing the skin lesions. And you have heard the distinction between the typical childhood variant and the typical adult variant. And this variant called monomorphic is usually predictive of a systemic disease, whereas this is a typical pediatric form and actually is usually associated with a limited cutaneous disease. But those are conditions that are quite easy to recognize. Basically, we have some conditions in which the skin lesions are not so defined and which are difficult to recognize. And we live also in a society which is multi-ethnic. And one of the challenges we have is actually recognizing those lesions in children and adults with other and with various skin types. So it's something that we need much more to recognize and where we need much better to apply our criteria of monomorphic and polymorphic variants. I think this question has been answered. Is a skin biopsy mandatory? Well, the diagnosis of cutaneous lesions is basically clinical. You have the lesions, you have the diarrhea sign Polina showed, and again, as Sigurd pointed out, the number of the mast cells in the lesion is not diagnostic. A normal mast cell by the pathologist will not exclude mastocytosis. An increased number of mast cells in the skin is not diagnostic of cutaneous mastocytosis. The second point is anaphylaxis. You have heard about the link and the association between anaphylaxis and Hymenoptera, eventually unprovoked anaphylaxis, and you've also heard about the scores. Both Polina and Sigurd showed the RIMA score. I would just like to point out some kind of challenges in application of this score, especially when it goes to the presyncope and syncope. Presyncope is quite an undefined symptom, and especially when it goes to cutaneous symptoms. You see that in the RIMA score, for example, every kind of cutaneous symptoms would reduce the probability that the patient will have a systemic mastocytosis. Whereas if you go in another score, applied in another settings, mainly in unprovoked anaphylaxis, you will see that different cutaneous symptoms might have different weight in your score. Independently of this, I think that we should add some granularity in terms of are really the cutaneous features absent in context of anaphylaxis in patients with mastocytosis, and which kind of cardiovascular symptoms are we going to consider. This is a study we have performed years ago in patients with a really low value of tryptase and in patients without skin manifestation of mastocytosis. And you see that again, hypertension and severe hypertension is a hallmark, but we have some patients with mastocytosis with coronal disease with other kind of cutaneous symptoms, such as, for example, flushing, and such as, for example, pruritus. And if it goes with triggers, again, there is an important association with Hymenoptera venum, but it goes in terms of number of events. It seems that patients without underlying coronal disease, they have much more events than patients with coronal disease, but maybe this is a bias because most of them have Hymenoptera venom-induced anaphylaxis, and we make prevention in this. This is the same results, but actually we come with another study conducted in the Netherlands in patients with wasp venom-induced anaphylaxis. And as you can see here, the most important manifestation that was predictive of systemic disease was a grade 4 anaphylaxis. That means a severe hypertension. The other question that was asked is whether we should use a specific cutoff for skinning of tryptase. And again, I can go quite fast because Sigurd already answered. Actually, there is no cutoff of tryptase that you might use for raising a suspect or for reducing the suspect of having a coronal disease. Tryptase is suboptimal. You might have no coronal disease for value that usually are considered elevated. And on the other way around, you might have a coronal disease in patients also with a very low value of tryptase. Something that already has also been shown in another study from the Netherlands, in which again, the value of tryptase in those patients was not exceeding the 10. And it's something that also Sigurd has shown in his study, in one of the seminal study in the evaluating the sensitivity of the KIT mutation, in which you have a lot of patients with tryptase below the 11.4, which is the company-based cutoff for elevated tryptase, and you might still have positive tests. And this is the result of a multicentric study we participated in, and you can see again that in Hymenoptera venum patients or in patients with proven mast cell activation, when you have an increase in tryptase, you have a high probability of finding your mastocytosis for tryptase below the 20 and even for tryptase below the 8. And you can see that if you correctly use also the tryptase genotyping in those patients, this population has been enriched for HAT. When you have non-specific symptoms, when you have an elevated tryptase, the HAT would be predictive eventually of a low probability of having an underlying coronal disease. Just because, as Sigurd said, mastocytosis is not the only situation in which you might have an elevated tryptase. There are different hematological conditions where you might have. There are different conditions, even in healthy individuals, and the most frequent cause of an elevated tryptase is this genetic trait that is called hereditary alpha-tryptasemia. And in hereditary alpha-tryptasemia, which is not a disease, which is a genetic trait, basically you have an increased number of alpha-coding TPSA-B1 gene. That means that the higher is the number of the copy, the higher is the value of tryptase. And there are several ways for correcting your value of tryptase based on the copy numbers. And this is a calculator that has been developed in collaboration also with John Line at NIH. Or basically, and roughly, you might correct the value of tryptase per 10 for each increased copy number of the TPSA-B1. In osteoporosis, again, you should not expect young patients, especially young male having osteoporosis. If they have, you should include, among the other disease, such as, for example, celiac disease, you should include mastocytosis in the differential diagnosis. There have been some scores. This is the osteo score that has been recently introduced by the Verona group, but basically suspect mastocytosis if you have a young male or female, especially a young male with osteoporosis. The other challenge, of course, is do not overestimate. I mean, do not estimate the probability that the patient will have a clonal or non-clonal disease just by looking at some kind of situation that are usually associated. And I think that Sigurd discussed a lot about this. We can go a little bit faster on this. The last challenge I would like to discuss, because I think it's also important, is the application of the diagnostic criteria. You have heard by Polina, we have major, we have minor criteria. The major criteria are the compact infiltrates, the minor criteria are the spindle shape, mast cells, the tryptase above the 20, the KIT mutation, and immunological abnormalities. But we are now in an era in which actually we have much more sensitive techniques than the techniques that were available at the moment that the criteria were performed. So, for example, you can see some situation in which, because of the variability of the tryptase, some patients, depending on the moment you take the tryptase, might have a tryptase below the 20 nanogram per ml, which is actually one of the minor criteria. If you go to the KIT mutation, you might have some discordancy between blood and with the marrow aspirate. Sometimes, even if it's robust, and I do agree with Sigurd, is the most robust test we have, you might fail to find the mutation only in peripheral blood. And also, you might have, since there is a really low burden, you might have some discordancy between the techniques you used for the KIT mutation analysis, even if you use high sensitive techniques. And this brings me to the situation we are facing now, especially in allergy settings, especially in patients with low burden, in which actually the patient the diagnosis is below the WHO threshold. You have patients who actually fulfill only one or two minor criteria, and actually they don't qualify as having systemic mastocytosis, and on the other hand, they have just one episode of anaphylaxis. They just have osteoporosis. In this case, you can even not call those patients as monoclonal mast cell activation syndrome, because they do not have the repetitive episodes of the mast cell activation syndromes. But again, those are patients that show signs of clonality or show some kind of aberrant marker. And why we cannot neglect those patients, and you can call whatever you want. We do not have agreement in nomenclature, but there is a reason why we don't need to, we should not ignore those patients, because if you see some clinical manifestation, they behave in the same way that bone marrow mastocytosis and indolent systemic mastocytosis behave. This is a population with a high frequency of anaphylaxis, and this is a population with a similar prevalence of the comorbidity of osteopenia, osteoporosis. Although those patients at the moment do not have a clear diagnosis and are also excluded of all the clinical trials that we have. So this is an important challenge we have now and in the future, and this is a challenge we need to solve. So for staying in time and for giving you some message, again, the principal message, and I think it's agreed with what Polina, with Frank, and Sigurd said, that mastocytosis can escape the diagnosis when we rely only on a single screening of diagnostic method. We should carefully look at the skin and correctly interpret the biopsy. Hypotensive syncope, hypotensive syncope should raise the suspicion of systemic mastocytosis, especially if it's induced by Hymenoptera venom. Do not use the tryptase outside the clinical context. Outside the clinical context, elevated or normal tryptase doesn't mean anything. And by far, at the moment, the most robust test for the screening of the systemic mastocytosis is the search of the mutation in peripheral blood by using a sensitive technique. Just Bear in mind that in few cases, the negative test does not exclude the disorder. We have in a new era of the disease, which we have much more sensitive techniques, so we make diagnosis earlier in patients with very low burden, and that means that we are now focusing and we are facing patients, they are below the WHO threshold, but even they behave in the same way that behave patients with indolent disease with bone marrow mastocytosis. This is why it's extremely important having a multidisciplinary team. And I thank you for all the attention. I thank again Frank and Polina for the invitation, and Sigurd also for the nice discussion we are having here. Thank you.
Vito, thank you very much. Perfect pitch, perfect in time. We are already on top of the hour, but we will have two questions for you. First is, you touched upon the challenges of detecting mastocytosis. So one example, patient with insect venom anaphylaxis comes into an allergy center. KIT D816V mutation is positive in the blood. What is next?
If you follow the criteria, if the KIT positive is in the blood, actually the patient should undergo a bone marrow, and then you might see whether it satisfies the criteria, yes or not. But in the clinical practice, in the real life, maybe the patient might be reluctant. Also because even if the patient will fulfill all the criteria, you are not going to change your management, because all the KIT positivity is more than enough for making your diagnosis. And the possibility of finding an associated myeloid neoplasm is quite low in these patients. So even if the patient is reluctant, the KIT in peripheral blood is enough for considering these patients as patients with a systemic disease. That means immunotherapy lifelong, and that means also an appropriate screening and follow-up for osteopenia and osteoporosis.
Super. So again, underscores the need and the importance and the value of KIT D816V mutation analysis in the peripheral blood, because this basically is the first and ultimate detection of a clonal mast cell disease, right? And then further steps can be
Again,
discussed.
nowadays is the most robust test we have.
Vito, one question. We didn't talk a lot on therapy today. This will probably be a topic of our next webinar, but just one point towards this. So do patients with indolent systemic mastocytosis always need treatment?
No,
And if not, when should they start treatment? Specifically
okay.
with the more modern and selective tyrosine kinase inhibitors.
How many hours do I have for answering? No, briefly.
3 seconds.
I don't think that any patients will need treatment. We are talking about tyrosine kinase inhibitor. We are talking about cytoreductive treatment. So not every patient will need. Probably for sure, candidate to the therapy are those patients with high symptom burden, which are not controlled with the anti-mediator therapy. The second group can be the patient with osteoporosis, which is actually not appropriately treated with current medication. Today, the approach of patients with osteoporosis is the same of postmenopausal, but we know that actually patients still have fragility fractures. And the third group might be the patient with unprovoked anaphylaxis that is under control. The other potential group would be the patient at risk of progression. And we need to understand who is the patient at risk of progression. And let me add to the KIT burden that maybe we have two prototype of patients with indolent systemic mastocytosis. The patient in which there is an onset in adults, and the patient with there is an onset in the elderly. The patient with an onset in the elderly usually have skin lesion, usually have high burden. This is a patient at high risk of progression, in my opinion.
Super, Vito. I think, as you said, that question could give half an hour of an answer. I think it is already the ideal topic for the next webinar. So watch out for the next webinar. It will be coming up. So thank you again. I can tell you we had a constant number, a high two-digit number of participants. So this clearly speaks for the quality and the interest of your talks. So thank you again, Polina, Sigurd, and Vito. And also thank you all for joining and for staying tuned. Although the weather outside is nice, at least in Berlin, Odense, and Antwerp, probably, hopefully also where you are located. Before you leave, please if you want to, and we would ask you to give feedback to this webinar, evaluate this webinar, there is a short survey, and if you scan this QR code, you are able to fill this survey. It will be very valuable to receive your feedback for planning of the next webinar. Also, if you want to stay tuned with the Galen activities and the MAST²CARE activities, you can scan this QR code or go to the websites. And be quick, if you want to even connect either via the websites or social media channels with, interesting topics, not only in mastocytosis, also in other mast cell-driven diseases like anaphylaxis, urticaria, angioedema, that are also aimed by the Galen networks, you can scan this QR code. Okay, with this, I'm in the end. Thank you all again for joining. Thank you for your very interesting questions. Thank you for staying tuned. And also thank you to our partners that made this webinar possible. Hope to see you all to the next webinar. And we already have the topic. We will definitely talk more about treatment strategies and the management of patients with indolent systemic mastocytosis. With this, I wish you all a pleasant evening and hope to see you again soon. Bye-bye.